The following program contains images of an actual surgical procedure that may be graphic and disturbing. Parents are advised that these images may not be suitable for young children.
We're live in the OR
with a groundbreaking alternative to open heart surgery.
No opening the chest, no stopping the heart. There it is. It's going around the arc.
Then,
is it ever okay for a parent to yell at their kid?
The doctors debate.
The effects of yelling can be as harmful as spanking.
Plus,
the average American consumes up to 152 pounds of sugar a year.
We've got the recipe for slimming down. That's today.
Welcome, everyone, to The Doctors. We have an exciting show today, starting off by going live in the OR to show you a procedure that's a groundbreaking non-surgical alternative to open heart surgery. This is a big deal, everyone.
So cool.
Yes.
Very cool. And join us now from University Hospital's Cleveland Medical Center is cardiac surgeon Dr. Joseph Sabic, interventional cardiologist Dr. Guilherme Adazani, and advanced interventional cardiology fellow Dr. Amar Alati, and their patient K, as well as the rest of the team. Thank you so very much for allowing us into the OR today. Can you explain to us the procedure that you're performing?
What we're going to see today is actually the replacement of a valve without opening someone's sternum, without putting them on the heart-lung machine, without stopping their heart, and without using general endotracheal anesthesia. They're going to be awake through the entire procedure. And the way this procedure is done is threading a catheter through one of the arteries in your groin called the femoral artery, and then the catheter goes through the present aortic valve that is very stenotic, and what that means is blocked. It's become calcified. And we're going to be able to deliver and place the valve that way. So again, no opening the chest, no going on the heart-lung machine, no stopping the heart, no general anesthesia.
Wow.
Can you talk a little bit about the benefits of this way of replacing the aortic valve versus the open heart procedure?
So for me to do what I need to do, we have to, open a chest, put someone on the heart-lung machine, and stop the heart. And patients go through a day or two in the intensive care unit afterwards, maybe 3 or 4 days in the hospital, and then a 6 to 8 week recovery time. Now we're talking about replacing someone's valve without doing any of those things, really with no incision, just a small puncture over the artery in the groin. And so the patients are spending maybe a day or two in the hospital, and then within 3 or 4 days, they're back to their normal life.
I'm sure the big challenge here, doctor, is you have a valve that's a certain size, I guess about 1 inch, but you have to pass that through a much smaller catheter. How do you do that?
You're exactly right. The technology that's involved in this is just, mind-blowing. It's all how that valve is loaded on the catheter. We call that crimping. And then when the valve is crimped and delivered through the valve, it is then allowed to enlarge and move the old valve out of the way, and the new valve sits in there very nicely.
Now, if there's someone sitting at home and they're planning to have open heart surgery, can you talk about who would be an ideal candidate for this procedure?
When we think about the universe of patients having aortic valve disease, some patients are high risk, some patients are intermediate risk, and some patients are low risk. Whenever we bring any new technology in, we want to make sure we're doing no harm. And so we tend to start these in patients who may be very high risk from surgery. We have equipoise there. And so when this technology was rolled out 6, 8 years ago or so, it was started in patients who were very sick, very high risk. And we looked at those patients and compared their outcomes with surgery and with this procedure. And this procedure was equally effective and beneficial because you didn't have the morbidity associated with surgery. Now we have studies that have shown that probably about another 20% of patients who have aortic valve disease, those with intermediate risk, are good candidates for this procedure as well. So today, we're allowed to do this in probably 20–25% of the population of aortic valve disease. And now we're doing studies looking at the majority of patients with aortic valve disease that are low-risk patients and see if this is an appropriate procedure for them. We'll know those results within the next few years. And one of the amazing things about this procedure is that many patients in the past who would not have aortic valve surgery because they were high risk or elderly and weren't candidates for surgery can have this procedure. And so today in the United States, more patients receive catheter or TAVR aortic valves than surgical aortic valves. It's really been an incredibly disruptive technology and incredibly beneficial for patients.
And just as point of clarification for our viewers right now who are watching this amazing procedure take place before their very eyes, your patient, Kay, is actually awake right now.
She absolutely is. As I said, the chest isn't open, there's no heart-lung machine, the heart will not be stopped, and she's not asleep. She doesn't have a breathing tube in. She's awake with us here.
Well, we're going to check back in with you all throughout the show. We're again honored to be a part of this groundbreaking procedure. Thank you so much.
Very welcome.
I knew when we started this show over a decade ago that it was a special opportunity to really break down some of the barriers between doctors and patients. That right there is pretty special.
Well, that heart surgeon is got it going. I mean, he just talked us through that while he was working like, I've got this. Very impressive.
Absolutely.
And like I said, we're going to follow through the OR throughout the show.
Coming up.
It's almost like a symphony. Everybody has their moves. They've done this many times, but it's really wonderful teamwork.
Then
Here comes the valve, and it's going in very easily.
Is this the most difficult part of the procedure?
It's the most important. It's critical.
that's coming up.
The following program contains images of an actual surgical procedure that may be graphic and disturbing. Parents are advised that these images may not be suitable for young children.
Earlier, we introduced a procedure to replace an aortic valve without open heart surgery. This is a transcatheter aortic valve replacement known as a TAVR procedure. It's happening right now in the cath lab at University Hospital's Cleveland Medical Center, and we are along for the ride. Dr. Sabik, Dr. Adesani, and the team have been busy. I have to ask, how's the procedure coming along, Dr. Sabik?
Oh, it's going very well. We're just about ready to put the valve on the catheter, so it's moving along beautifully.
That's it, right?
That's the valve. That's the actual valve that's going to go into our patient today.
Oh, that's remarkable.
And when you pass it, it sort of fixes itself in place? How does that work?
So what happens is we're using imaging, and we're using fluoroscopy, which is X-ray, to know where we are. And there are certain landmarks that Dr. Adesani is looking at. And so he positions the catheter and then positions the valve exactly where he wants it to be under direct imaging. So it's real time. And then he blows up the valve, releases the valve, and it's the radial force of the valve that holds it in place. Now, how does the valve work? And it really just works because of the pressure differential. You know, when the heart contracts, it pushes the blood, which opens the leaflets, and the blood comes out of the heart. And then when the heart relaxes, the blood starts to come backwards, which catches those leaflets, and those leaflets then close. So it's just very simple fluid physics, I suppose. Okay, so what we're now doing is starting to load the valve, you know, onto the catheter. And that's the crimping that we talked about. As you all saw a little earlier, Dr. Adesani had showed you the valve and how large it is. You know, it's got at least 1 inch in diameter. And now we want to take that valve that was blown up and now crimp it so it can go on a very small catheter. You can also see the device. It's, like I said, it's an amazing piece of technology. I suppose when you think about it, when we think about heart surgery, it's a lot of technology, and they've been able to take what we would normally do with a heart-lung machine and general anesthesia and put it on a catheter. So we shouldn't be surprised that this is a complex technology and procedure, but you're going to see it done, and it's going to look so simple.
What is the time sequence in a typical procedure like this? How long does it usually take you?
Literally, it can take an hour 2 hours. I don't know if you can see it, but the valve is crimped and loaded onto the catheter. And Dr. Adesany is just about ready to take it, and the procedure will be happening momentarily.
How long does this procedure typically take if you're doing open heart surgery?
About, 3 to 4 hours. It usually takes us maybe about 45 minutes to an hour to open the chest and get the patient on the heart-lung machine, and then about another 45 minutes with the heart stopped while the valve is implanted. Then we let the heart recover. But I'm going to come back here, and here you can see the fluoroscopy, and you can see the valve that's crimped now on the catheter. And Dr. Adesany is now going to be positioning this in a very short time.
Valve is well crimped.
Thank you.
Okay. All right. Go back to the projection, please.
20 true deal.
20 true deal. Going in. Back to the projection. So what we're going to do now, we're going to pre-dilate this valve to enable the new valve to go in. We're going to go with a balloon inside.
So to prepare the valve for the TAVR valve, Dr. Adesany is going to dilate the valve. So when someone gets aortic stenosis or a blocked valve, it's very calcified. It's almost like rock hard. And so he wants to prepare that so that he knows that his valve can open very well inside the patient's native valve.
Feed me wire. Feed me wire. Feed wire. I'm going to pull back the balloon. Feed wire. Feed.
And you see that wire that looks like it's curled, that is actually inside the patient's heart right now, inside the main pumping chamber, the left ventricle.
Need to deflate a little bit.
The other wire you see is actually a pacemaker wire that's in place, the one with the 2 dots on it.
Okay.
They're going to position the balloon,
Good. Thank you.
and then the balloon will be inflated inside the patient's native valve so it can open. It's called a balloon valvuloplasty.
Go in and hold the wire, please. Push the wire a little bit.
This is what we would do a long time ago before we had artificial valves. We would just, in a patient who wasn't a candidate for surgery, just do a balloon valvuloplasty to help them. Unfortunately, it doesn't last very long, maybe a month or 2, and the aortic stenosis comes back.
I'm going to make your heart beat very fast right now.
Now, one of the things that they're doing is they don't want the balloon to move or the TAVR to move when they position it, so they're going to make the heart beat very fast. This allows the heart not to pump blood out, and so the balloon will stay in position. It's only done for a very short period of time. So now they're pacing her heart very fast, and so her heart is not ejecting right now. So no blood is going anywhere. And now they dilate the valve, and now let her own heart come back and let her heart eject. So that's how short it was, a very short period of time. But during that time, there's no blood being ejected from the heart, so that balloon does not move. It stays exactly where it is, and that's very important.
Keep it straight, please. Good. Keep it, push the wire in a little bit. Good. Almost out. And I'm out. It's okay. I got it. Okay, balloon out, please. All right.
Okay, so now we're getting ready to position the valve. And the nurse is bringing the valve up to the table. Again, it's been crimped and loaded on the catheter. And you'll see once, it doesn't take very long now that everything has been prepared.
Hold the wire, please. I'm just connecting the RFA here, guys. Okay, ready there? Go there, push the drum. Pay attention to the wire, Arthur. Go to there. You guys ready? All right.
Now these catheters are positioned over wires. And the wire, again, is in the heart itself through the valve. And the TAVR valve is going to be passed over this guide wire and then positioned. And again, this is done under direct vision using fluoroscopy, which is the X-ray technology, which allows us to see exactly what's happening.
Okay.
Even though, again, there's not an incision on the patient's chest.
Remove the big IV we have in. And you're going to feel pressure. And we're going to
the amazing thing, you probably can hear it, but Dr. Adesany is having a conversation with the patient as this is going on so that they're aware of what they're going to feel and what they're going to sense, and so there are no surprises for them. It's absolutely amazing.
16 cranks out. All right. Bring the wire to the tail.
And you can see it's almost like a symphony. Everybody has their moves. They've all known their moves. They've done this many times. But it's really wonderful teamwork. Everybody knows their part and what they need to do to make this a success.
Okay, you're gonna feel that pressure in your groin now, darling. Okay, I'm gonna insert the valve now. All right. Who has the wire?
And so the valve is now being introduced into the artery in the groin called the femoral artery. And Dr. Adesany has just put the crimped valve that's on the catheter into the patient. And you can see on the fluoroscopy, the valve has now entered the patient's chest, but it's not in quite position yet. And he's now going to spend the next few minutes putting the valve in the correct position. You're going to see it slide around. It's in a large blood vessel called the aorta, which comes up the patient's back and then takes a curve, and we call that the aortic arch. And you're going to see the valve curve around the arch and then come down into the ascending aorta. Here it is. It's going around the arch. It's going around the curve, and it's coming down into the ascending aorta. And the beginning of the ascending aorta is where the heart meets the aorta, is where the aortic valve is. And so that's where he's going to position the artificial TAVR valve. And again, it's all done by visualizing it with x-rays.
More of this amazing procedure when we come back.
Coming up.
Here comes the valve, and it's going in very easily.
Is this the most difficult part of the procedure?
It's the most important. It's critical.
That's next.
We're back in the cath lab at University Hospital's Cleveland Medical Center for a transcatheter aortic valve replacement, or TAVR, procedure with cardiac surgeon Dr. Joseph Sabik, interventional cardiologist Dr. Guilherme Adesany, and advanced interventional cardiology fellow Dr. Amar Alati. Again, watching this fascinating procedure take place live today.
And so here we go.
Great. See the projection. Go to the projection.
He's just getting all of his x-ray machines perfectly positioned so that he can see exactly what he wants to see. So there's no ambiguity as to where he wants this valve to be.
Yeah, it's fine. All right. Good. Okay, who has the wire? Hold the wire.
And here comes the valve.
Very smooth.
And it's going in very easily.
Good. We have enough contrast there?
He's going to put a little contrast, again, to help him know where he is.
Is this the most difficult part of the procedure, Dr. Sabik?
Well, it's really but it's the most important. It's critical. This has to be done right, because if we put the valve in the wrong place, it's not going to work. So you just want to be perfect. So it's always, as you know, at these critical steps, you just take a little bit more time. You convince yourself you know exactly where you are, and that way, when you release this valve, it's in the right place. So it's worth just, you know, pausing a little bit, double checking and double checking again.
We have total control, blood pressure is fine, everything's good. Let me mag one up now.
And again, the patient's being monitored. We know her heart rate's fine, her blood pressure's fine. We can talk to her and just take our time and get this right.
Part of a turn. Keep coming. Very slowly. Slowly. Okay, are you okay there, darling?
I'm fine.
We're putting the valve, okay?
I'm fine.
Great. Keep
And
coming.
you can see the valve is starting to be released.
Keep coming slowly. Keep coming over. Part of a turn. Part of a turn. Buff me. Good. Part of a turn. Stop. Just let the energy now. Stored energy to come out. Another quarter of a turn. Another quarter of a turn. Buff me. Okay, we're going to start
the
facing
valve
her.
starting to come out of the sheath. It looks a little bit like an umbrella that's going to open. And then it's kind of like an umbrella type of opening. You see the arms coming out either side. Now, as they're doing that, they're sitting inside the patient's own aortic valve that has been ballooned open. And then that's what's holding this radial force as that valve's being released. And it's just about in place.
Coming up.
Is the new valve now correctly in position?
That's next.
The following program contains images of an actual surgical procedure that may be graphic. Parents are advised that these images may not be suitable for young children.
And here you can see they put some dye in the ascending aorta, and they see that the valve is functioning. You see all that dye is staying above the valve. That's a really good sign, because now we know that the valve is not leaking into, the dye is not leaking into the heart, and our valve is functioning well.
At this point in time, Dr. Sabik, with checking whether or not anything flows back into the heart, is the new valve now correctly in position?
Yes, and it's working. It's just not completely released. Again, just checking to make sure everything is clear.
And do you, obviously, you hit it on the first try here. Is there a mechanism that if you need to reposition it or redo it, you're allowed to do that?
Yeah, that's why we haven't let go yet. It can be resheathed. It can other things that can be done just to make sure that we're real happy with it. That's a great question. But we want to get it right the first time.
Okay. Dr. Sabik, we're going to take a quick commercial break so that you guys can completely finish, and we're going to check back in shortly. Once again, thank you for letting us be a part of this, and you could have a future as a play-by-play announcer for surgery because you are absolutely phenomenal at this. Thank you. We'll be right back, everyone.
Coming up,
Was the procedure a success?
plus,
Always ask your doctor, what are the options?
that's in today's doctor's prescription. That's next.
Throughout the show, we've been fascinated. We've been live in the OR at University Hospital's Cleveland Medical Center following an aortic valve replacement through a catheter. Cardiac surgeon Dr. Joseph Sabik has been doing play-by-play, and a wonderful job, if I may add. Interventional cardiologist Dr. Guilherme Adesanya and advanced interventional cardiology fellow Dr. Amar Aladi have been doing this procedure. And I have to ask you all, docs, was the procedure a success?
It was a complete success. You know, since we last talked, the procedure is completed. You know, the valve is completely in place. It's being held in place by itself. It's no longer attached to a catheter or a wire. And we also did an echocardiogram, which is an ultrasound examination of the heart, which showed that the valve is working perfectly. There's no leak, and what we would call the gradient, which is the kind of the pressure drop across the valve, is very low. We are very happy about how everything worked out today for Kay.
And docs, if Kay can hear me, I was just going to see if Kay could say how she's doing right now.
Great.
She said great.
And is this procedure available across the United States?
Yes. The procedure over the last 6 to 8 years has grown to, I think, over 500 centers now in the United States do this procedure.
And so how can someone find a doctor who does it?
Well, I think that the easiest thing is to talk to your doctor. Obviously, find the cardiology groups and cardiac surgical groups that are expert at aortic valve replacements and TAVR procedures, because it's something we do jointly together, and then set up an appointment and talk to them.
Well, docs, I want to thank each and every one of you, as well as you all watched that take place. Don't forget that teamwork. Every single individual in the cath lab there, thank you for allowing us to be a part of this. Truly remarkable to see you all do your jobs, and certainly we're so happy for Kay, and thank you for allowing us into the OR. As we always say on our show, before you have a procedure, before you have surgery, always ask your doctor what are the options. In a case like this, if you're scheduled for an aortic valve replacement, talk to your doc. Hey, is this the best procedure for me? Is open heart surgery better? Is this possible transcatheter approach the best way to go? Always ask, and that really is going to be our prescription for the day. Just make sure you know all of your options before agreeing to any major procedure or surgery. Make sure you get the right operation or procedure for you. If you missed anything on today's show, visit us at thedoctorstv.com. We'll see you soon.